Hi, this is Amanda Kocher, and I am looking at respiratory acidosis and associated compensations today. So let's start with what it looks like in a balanced state or in a healthy situation where our pH, which is our acid-base balance, is able to be at a normal range, which a normal ratio of bicarbonate to carbon dioxide in the body is about 20:1, which gives us a normal pH value of roughly 7.4 on average. Just as any other homeostatic state in the body, the pH range and being in that general area is important. And as you look at that balance, if it gets out of whack, if it becomes imbalanced, that can be detrimental to health, whether it goes more acidic than it should or more alkaline than it should. So in the cases of acid and base balance in the body, we have respiratory and metabolic mechanisms in place in order to balance the pH of the body. In today's presentation, we are looking specifically at respiratory acidosis, though they are all kind of interrelated, and so we'll just kind of focus there, but also go into a little bit of how they relate to the others. So in this general state, as we see here on the right, we have our bicarbonate on the right, you have carbon dioxide concentration on the left, and our ratio is about 20:1. So you have your 20 molecules to 1 molecule here. And as we go through and look at that, that is what creates our normal acid-base balance in our body. In the case of respiratory acidosis, though, we have abnormally high carbon dioxide levels, which are going to increase the hydrogen ion concentration of the body. This is caused by hypoventilation of some sort. That could be caused by any number of factors, but primarily these things go into things like lung disease. You could look at nerve and muscle disorders that disrupt the actual muscle ability for inspiration and expiration to occur. Even just holding your breath could cause some short-term respiratory acidosis, though your body can correct for that relatively quickly. And then finally, you could have a drug-induced depression of respiratory centers for any number of reasons, which we will talk about here in just a little bit when we look at our study. But when we look at this diagram here, if we look at the left, we have this is our kind of uncompensated area here. So you have your bicarbonate here that's still at that 20. But if we double the carbon dioxide that is seen, our pH decreases, and our ratio is 20:2 rather than the normal levels of 20:1. Now, this being said, one thing to kind of note in this is that lopsided ratio of bicarbonate to carbon dioxide is important, because if you increase the carbon dioxide, it is going to have a much, much greater impact than if we increase the bicarbonate. So if we add just a small amount of carbon dioxide to our system, it will have a much greater impact, because the level of bicarbonate at any given time, or the concentration of bicarbonate, is about 600,000 times that of our concentration of hydrogen ions associated with that carbon dioxide. So increasing carbon dioxide has a great impact, either detrimentally or when we get to the point of being able to balance by removing that carbon dioxide, it is helpful. So we'll look at the compensation piece. Okay, so this is kind of zoomed in on that right side of that diagram just because that is what we're looking at with the compensation now. We have several mechanisms that help us do this. So we have chemical buffers, but the primary way that we compensate for respiratory acidosis is through the kidneys and renal conservation of that bicarbonate, and by adding additional bicarbonate to the blood plasma. Additionally, our kidneys can also help us excrete those additional hydrogen ions to help bring that pH balance back to our happy place of roughly 7.4. So in our compensation diagram here, we see we have doubled our bicarbonate by conserving it, or adding it to the blood plasma. And so now we have this ratio of 40:2, which reduces to 20:1, which is what our normal concentration ratio would be. As the pH can return to 7.4, we have that balance. And that's what's key. It's not so much about the specific number of bicarbonate molecules or the specific bicarbonate concentration, but rather a balance between that bicarbonate and that carbon dioxide, and whether or not those two things are in balance or not. As long as they are in balance, regardless of what the raw numbers are in terms of amounts, we still get this balance, and then that is considered compensated in terms of pH, because we just want to get back to this nice, happy, homeostatic level pH of roughly 7.4. So I mentioned that our study today looks at that drug-induced depression of ventilation or drug-induced causes for respiratory acidosis. So there's a study done in 2016 that looked into the mortality outcomes for patients that had acute poisoning that influenced their acid-base levels, and so kind of disrupted that acid-base balance that we just talked about. While this has been studied in acute injury, acute poisoning at the point of the study really has not been very well studied and very well reasoned out. So this study took a retrospective approach, but was able to include over 1,100 patients, which is pretty amazing in terms of a study size. It gives us a good sample size to work with to help it be a great initial study for this type of work. They hypothesized that the on-arrival acid-base disturbance levels could be associated with prognosis and mortality of these patients. So they thought, if we can measure this on arrival, then maybe there's a way we can look at what patients should be moved to critical care more quickly, should be more closely monitored, so that we can avoid mortality in those patients. And so, as I said, they took a retrospective approach, and they used patients that they had blood gas measurements for, both arterial and venous measurements for, so that they could look at this acid-base disturbance in depth. And so what they found as they went through their study, of the 1,167 patients here, so we have our raw numbers here, and then in our parentheses throughout, we have our percentages of the patient population. 98 patients died of the patient population that was looked at. And so what they found ultimately was that while acidosis can be a predictor of poor outcome in critically ill patients as they come in, more often we see primary respiratory alkalosis. So we see either a mix of the primary respiratory alkalosis and metabolic acidosis that is having a significant impact with our p-value here. So if we have 10 patients that died that came in with that on arrival respiratory alkalosis and metabolic acidosis together. And that severe metabolic acidosis is actually more or a greater indicator of these poor outcomes or poor prognoses than simply respiratory acidosis is. Our primary respiratory acidosis, still though, while not significant, was right there in the study looking at those levels. So taking that a step farther, the study looked at what are those common intoxicating substances that were seen that caused respiratory acidosis or caused any other issues. And so opioids, which we are facing an opioid crisis still, but what they found was if we look at our opioid levels, our opioid agent, we see that opioids were the primary cause of respiratory acidosis, and they also were the primary cause of death in those patients that suffered from acidosis, or respiratory acidosis, excuse me. But they also found that the benzodiazepines, pesticides, and alcohol really were not that far behind those levels, and so they kind of closely followed that trend. And ultimately, this study concluded that the primary respiratory alkalosis and severe metabolic acidosis, separately or combined, are what are more likely to increase mortality. And kind of the implications and why this is important is that it lets clinicians know and lets healthcare systems know that really taking those blood gas measurements on arrival in the case of acute poisoning is important. That can help emergency departments treat and figure out who needs the most help the quickest so that they can hopefully recover and get to return to a normal life. Thank you so much and have a great evening.